Good afternoon. My name is Chris Herrick, and I'm the Deputy Commissioner for the Life and Health Division. I'd like to welcome you to the 2022 Virtual Compliance Conference, and thank you for joining our session today, which is Achieving Success with Your Rate Filings. Today's presenter is Michael Markham, who is our Interim Chief Actuary in the Life and Health Division. At the end of the session, there will be a question and answer time with Bing Wu and Sean Fry. If you have any questions during the session, please type them in the Q&A box. Let's get started, and thank you again.
Hello, my name is Michael Markham. I am the Chief Actuary of the Life and Health Actuarial Office, and I'll be doing a presentation of the Affordable Care Act Rate Review. This presentation will consist of three parts: the rating area realignment, ACA rate filing review, and the cost share reduction subfactor defunding adjustment. The Texas Department of Insurance, TDI, has been instructed by a recently passed law, Senate Bill 1296, by the 2021 legislature, that's the 87th legislature, to adopt rules establishing geographic rating areas and a process for reviewing the rates of ACA-compliant individual and small group health benefit plans. PHRs were originally developed by the Texas Health and Human Services Commission, HHSC, and TDI's current regulatory rules allow provider networks to develop their service areas using these PHRs. This presentation will highlight a couple key changes, including the Texas Rating Area Realignment and new guidance for the cost sharing reduction defunding factor. For rating area realignment, we have changed from the current 26 rating areas to 27 rating areas. The public health regions, PHRs, were originally developed again by the Texas Health and Human Services Commission, and TDI's current regulatory rules allow for provider networks to develop their service areas using these PHRs. The proposed geographic rating areas coordinate the PHRs with the metropolitan statistical areas. As far as the ACA rate filing review, TDI is instructed by the recently passed law, Senate Bill 1296, to become an effective rate review state for calendar year 2023. And as of a week ago from the recording of this, we have been designated by CMS as an effective rate review state. So we have achieved that goal. Again, and finally, the cost share reduction defunding adjustment. We've established new rules and guidance as we will present in this presentation. We have 6 objectives for the rating area realignment. One is creating rating areas that better correspond to the hospital, specialty, and tertiary networks with the major urban areas. Assigning rural areas to the most appropriate urban area to ensure that premiums more closely reflect claims costs in their geographic area. Increase competition by creating geographic rating areas that will encourage insurers to expand to cover all counties in the rating area. Achieving more straightforward pricing and rating areas by eliminating large claim cost differences within geographic rating areas. Expanding choice in rural counties, giving residents greater access to affordable health care coverage. Highlighting high-cost rating areas to encourage provider expansion into these areas and increase competition. If we go to the next slide, this is a slide of the 254 counties within the state of Texas. And the graph to the right shows that the 186 Texas counties with population less than 50,000 in 2020. Rating Area 26, which is a collection of 177 of those counties that are not part of an MSA, is spread across the entire state. Due to the vast differences in medical costs throughout the state and the inability to vary premium to align with costs, the only carrier to cover most of these counties is Blue Cross Blue Shield of Texas. Blue Cross Blue Shield operates at a loss in many of these Area 26 counties. So if Blue Cross Blue Shield should decide to no longer sustain the loss and to cover in these rural counties and withdraw from the respective service area, residents would have no major medical insurance available in the individual market, and Blue Cross would be prohibited to return to these counties for 5 years. When we look at the individual market, we look at the number of competitors by county, we can see that for a lot of these rural counties, as I've said, they only have one carrier. In other counties, they may have two. We see a lot of these counties with only one carrier is often driven not only by the fact that they're rural, but also by the public health regions, particularly for some of the higher cost public health regions. They have become more competitive, so the one carrier is shrinking, but we believe with the rating area realignment, we'll encourage carriers to not only cover the entire state, but to also cover the rural counties around the MSAs. Okay, so when we look at the current rating areas, the MSA definitions do not take into account medical cost differences between the MSA. Insurers have defined service areas by county, permitting insurers to limit coverage to a subset of the geographic rating area. Insurers are at a disadvantage if coverage is provided over the entire rating area, since competitors can undercut premium by only covering the lower cost counties. Major medical premium rates within a state under the Affordable Care Act may vary only by plan design, age, and geographic rating area. The default geographic rating areas alignment at the inception of the ACA was the metropolitan statistical areas, with the remaining rural counties aggregated in an additional rating area. Insurers that attempt to cover the entire rating area can only discontinue coverage by withdrawing from the entire state for PPOs or service areas for HMOs for 5 years. The drastic difference in medical costs between, for example, Dallas County and Tarrant County, that's Fort Worth, and rating area 8, and then the Houston rating area 10, has resulted in most major carriers totally withdrawing from the individual market and only maintaining a presence in the small group market by offering coverage at a non-competitive premium. Rating Area 26, which is a collection of the 177 rural counties that are not part of the MSA, is spread across the entire state. For counties in Rating Area 26, which covers much of the state of Texas, the medical costs in each are largely divided by the closest metropolitan area to the county. This is intuitive since residents are likely to go to the nearest hospital or medical center for specialty and tertiary services not available in their home county. Due to the vast differences in medical costs throughout the state and the inability to vary premium to align with costs, the only carrier that covers most of these counties is Blue Cross Blue Shield. Blue Cross Blue Shield operates at a loss in many of these Rating Area 26 counties. So we began looking in our redesign at the public health regions, which is the most common, the most logical common framework to develop geographic rating areas are the 11 public health regions. TDI uses public health regions to assess PPO network adequacy. Using PHRs along with MSAs, aligning rural counties to the most appropriate MSA, and further dividing rating area to the major metropolitan area of Dallas-Fort Worth in Houston results in a more appropriate design for geographic rating areas. As can be seen with the graphs, realigning rating areas along PHRs and further segregating by urban areas within each PHR is our recommended approach to achieve TDI objectives in realigning geographic rating areas. So what we've done is we've taken the public health regions and we put that over the current rating area configuration that we have. That's the 26 rating areas. So we begin with that. Again, using public health regions along with the MSAs, assigning rural counties to the nearest MSA, and further dividing rating areas into major metropolitan areas of Dallas-Fort Worth and Houston results in a more appropriate design for geographic rating areas. So we begin with this, and then we subdivide even more, as we see in the next slide. And what we've done is we've basically, in our division here, is that we've put the rural counties in the closest city. We've also combined rating areas Midland and Odessa because we see that as really one metropolitan area. Large carriers such as Humana, United Healthcare, Aetna, and Cigna withdrew from the individual market in large part due to the inability to adjust premiums to reflect claim costs under the current geographic rating areas, resulting in 5-year bans from the Texas individual market. The companies that have remained in the small group market have maintained little more than a presence. This slide here shows the rating areas now with the color designation, so you can see the 27 rating areas. We believe that this realignment will encourage large carriers back into the Texas individual and small group ACA market and encourage smaller carriers to expand into the rural counties. The reason that we expect that this will happen is that it just makes sense to go into the rural counties around the cities. Costs for rural counties around the cities, the cost is expected to be less because there's an expectation of lower utilization. So it only makes sense for carriers to expand to cover the entire rating area. Okay, now that as we can see, the new geographic rating areas that will be in effect for 2023, let's look at some of the factors that we looked at in determining the new rating areas. Drivers of rate variation by rating region. Rating variations are driven by lower utilization, especially prescription drugs in South Texas, higher prices, especially for hospitals, single hospital markets, morbidity. It's hard to tell. More analysis will be needed. Are prices higher, utilization different in rural areas? Healthcare costs in rural areas logically are driven by costs for specialty and tertiary services in the most proximate urban area. Rating Area 26, not surprisingly, a composite of costs for the host state. Premiums are not higher or lower. Recommendation: premiums should be set more on a regional basis. A reflection of prices encourage providers to work within regions to improve outcomes and to control costs. So by putting the rural areas into the rating areas of the nearest urban area, it also encourages providers to provide efficiencies in care in those areas because they have a broader market. Okay, how the realignment could benefit rural communities. First, by expanding insurance options in rural communities. Expanding insurance options for individual and small employers. The first pathway would increase the percentage of rural adults with health insurance because low-income children and other adults are eligible for public insurance coverage through Medicaid, CHIP, and Medicare. The individuals most likely to be uninsured are those between ages of 19 and 64. To increase insurance coverage in rural Texas, a realignment would need to increase insurance options through the individual and small group markets. These options would need to be lower cost or provide better benefits than current existing options in order to motivate participants by individuals and small business owners. By putting the rural counties into the same region as the major cities, it'll encourage insurers to expand into these rural areas. By having the prices reflect the cities in that area, even if they have a higher price, it'll increase the federal subsidy since the federal subsidy is based on the second lowest silver plan. Increase funding coming into or retained in rural healthcare. The second pathway would strengthen the viability of rural healthcare systems by increasing funding available to rural healthcare systems. An increase in funding will be supported by increased coverage, but can also be achieved by other means, such as increased payments, greater efficiencies, and grants to cover one-time infrastructure improvement costs or a portion of ongoing fixed costs. By having the prices of premiums that more closely align with the cost, as I said, it'll increase the federal subsidy dollars that will be dedicated to coverage in these areas. Supporting a transition to value-based health care. That's the third pathway. A third potential pathway to rural health care improvement would involve supporting the transition from traditional fee-for-service payment approaches into value-based and accountable care models that offer a promise of greater value, better health outcomes for healthcare dollars while lowering costs through improved care coordination. The transition is widely seen as the future of healthcare, and healthcare payments in the U.S. has been mentioned as critical to the relevance of a realignment by our project's key informants and advisors. The future requires a new approach to providing healthcare, including increased coordination and collaboration within healthcare and partnerships with non-clinical care providers to address social determinants of health. The foundation pathway. Underpricing this framework is a foundation of greater rural control and a primary driver from the initial enabling legislation. Of note, potential benefits are not limited to those described in this framework. For instance, they may include development of Medicaid plans that are a better fit for rural communities. But by highlighting the higher cost rating areas, we believe that it'll encourage providers to come into these areas when they see the higher costs. That will increase competition in these higher cost areas, but will also encourage better coordination of care and more efficiencies of care and a higher transparency of care to help lower the cost in these areas. That is the third objective in the realignment. So now, as we move on to the geographic rating area realignment, now we'll go to the requirements for filings beginning in the 2023 year. Rate filing for health benefit plans, that is ACA plans, individual and small group market, is given in the Texas Administrative Code 28 TAC 3.501 to 3.506. Important dates to remember with the annual ACA rate filings: they must be submitted by June 15th for rates, with January 1st as of the effective date. For small group quarterly rate filings, filings with effective dates April 1st, July 1st, or October 1st must be submitted at least 105 days before the effective date. TDI may request individual information as necessary upon initial review of the filing. The issuer must provide the requested information within 10 business days. Now, the rates that are filed June 15th, we understand that many carriers will refile, and this is okay, particularly after the risk adjustment report comes out at the end of June. But companies can simply refile their rates, and we'll have an expedited review of the rates. Information that must be included with the initial filing is the Unified Rate Review Template, the URRT. For a rate increase that is 15% or more, a written description justifying the rate increase must be included. It must also include an unredacted and signed actuarial memorandum. Also is required is the rate table template, the RTT. This is the same template which you have filed with CMS for years. We also require the enrollment spreadsheet. We have a Texas template which will show enrollment as of March 31st of the current year. This is the same template that we have required annually, It's just that instead of a May 31st date, we have it as of the end of the first quarter. The Texas template will also include the distribution of enrollment for on-exchange silver plans so that we can track the enrollment for on-exchange silver plans. We also will have an additional template, the actuarial value and cost share factor design template, a Texas template. These will include the three sub-factors which compose factor 3.3 in the URRT. This includes the pricing actuarial value, the induced demand sub-factor, and a cost sharing reduction, the CSR sub-factor. In regards to the induced demand sub-factors, we require specific values to be used. For catastrophic and bronze plans, we require that the value be 1.00. For silver, 1.03 must be used. For gold, 1.08, and for platinum, 1.15. Induced demand factors within the state payment transfer formula was developed in 2014. The determination was that we should account for induced demand associated with two separate sources. The planned generosity differences between the metal levels and enrollee receipts for CSR, which result in greater generosity of CSR plan variations relative to standard plans. As such, CSR IDFs that is used in payment transfer formulas was introduced by CMS. For those who are unfamiliar with the induced demand factor, a layman's understanding of the induced demand factors would be a change in utilization, or I'll also refer to it as the likelihood that someone is to seek medical care. It is believed, and statistics show this, that people who with richer plans are more likely to seek medical care. This is due for two reasons. People with medical issues tend to buy richer plans, even though they cost more. Also, people who have richer plans, the one which have lower cost sharing, people tend to go to seek medical care more because their cost sharing is less. Okay, for the sub-factor spreadsheet, the actuarial value and cost sharing factor design template, you have a screenshot at the bottom of this slide, which shows how these of what this spreadsheet will look like and the factors that are required. For the cost sharing reduction sub-factor, for all metal plans except for silver metal tier on exchange plans, the CSR sub-factor should be 1. For silver plans, which are on exchange only, the CSR sub-factor should be a 1.35. In regards to the CSR sub-factors, background of CSR defunding. In October 2017, the federal government ceased funding of the CSR, forcing insurers to assume financial responsibility for CSRs. The Centers for Medicare and Medicaid Services, CMS, permitted insurers to recoup these costs in their premium by adjusting a factor in pricing of plans. To account for CSR payments not being reimbursed, a CSR defunding adjustment of 1.35 should be applied to on-exchange silver plans. The CSR calculation is developed based on the weighted actuarial value of silver plans, including all CSR plans in Texas, and also the weighted induced demand factors based on generosity of the silver plans. QHPs are permitted and encouraged to map individuals who will otherwise be enrolled into non-CSR silver plans and CSR 73 plans into a GO plan as long as the GO plan has a net premium equal to or less than that will be paid for the member's current silver plan in plan year 2023, or the silver plan in which the member would otherwise be enrolled if their plan is being discontinued. And 2, has the same network of providers as the member's current plan. Now we'll cover how the CSR subfactor was determined. First, I'll give you an overview of certain terms which are used in the calculation. First, CSR eligibility is based on income as a percentage of the federal poverty level. So the plans which consumers will be eligible for will be based on their annual income. Based on the increased richness of each plan available is measured by actuarial value. Actuarial value is defined as percentage of allowable costs, which is actually covered by the insurer. So when you see an actuarial value of 0.7, that means for every dollar that the provider charges, 70 cents is covered by the insurance, and 30 cents is covered by the member. So the richer plans that you see here, there's less cost which is associated with the member. The IDFs, the induced demand factors, is a measure of utilization, the likelihood that a member is to seek medical care. When we determined the CSR factor, we looked at the enrollment distribution in 2021 for on-exchange silver plans. As you can see, the enrollment in 2021 was heavily favored the CSR of 0.94. When we conduct a weighted average of enrollment, we had a factor of 1.287. We also weighted in the increased likelihood that a member with these richer plans are to seek medical care. When we have an actuarial value of 0.87 and also at the 0.94, these plans in reality become platinum plans, which would have an increased demand factor, an IDF of 1.15. But we did not feel that the increased demand would achieve the 1.15, mainly because members are not getting these plans because of poor health, but they're really getting these plans because of availability. We concluded that the induced demand, we concluded that it would be higher, and we settled on a factor of 1.08 for an actuarial value of 0.87 and a slightly higher of 1.09 for that 0.94 actuarial value. When considering the induced demand factors into the calculation, we end up with a CSR factor of 1.35. So this is how that value was determined. In filing rates filed under this subchapter, CDI will examine the reasonableness of assumptions used by the issuer to develop the rates and the validity of the historical data underlying the assumptions. The issuer's data related to past projections and actuarial experience. The reasonableness of assumptions used by the issuer to estimate the rate impact of reinsurance and risk adjustment programs under 42 U.S.C. 18061 and 18063, and the issuer's data related to implementation and ongoing utilization of a market-wide single risk pool, essential health benefits, actuarial value, and other market reforms rules as required by the Affordable Care Act. TDI will determine that a rate filing is unreasonable is based on the criteria identified in this subsection. The rate is excessive, unjustified, or unfairly discriminatory. A rate filing is excessive if it causes the premium charge for the health insurance coverage to be reasonably high in relation to the benefits covered, in relation to the benefits provided under the coverage. In determination whether the rate filing causes the premium charge to be unreasonably high in relation to the benefits provided, TDI will consider whether the rate filings results in a projected medical loss ratio below the federal medical loss ratio standard, that is 80%, and the applicable market to which the rate filing applies, after accounting for any adjustments allowable under federal law. Whether one or more of the assumptions on which the rate filing is based is not supported by substantial evidence, and whether the choice of assumptions or combination of assumptions on which the rate increase is based is unreasonable. TDI will determine that a rate filing is unreasonable if, based on the criteria identified in this subsection, the rate is excessive, unjustified, or unfairly discriminatory. A rate filing is unjustified if the issuer provides data or documentation that is incomplete, inadequate, or otherwise does not provide a basis upon which the reasonableness of an increase may be determined. A rate filing is unfairly discriminatory if the filing results in premium differences between the insureds within similar risk categories that are not permissible and do not reasonably correspond to differences in expected costs. If you have any questions regarding rate filings that were not answered in this presentation, feel free to contact me or Michael Markham at the email address provided below. Or you can also contact Bing Wu or Hector Garza, who are responsible for rate review filings for the ACA market. Thank you very much.
Hello, everyone. Thanks for joining us today for our webinar on the ACA rate review process. I'm Ben Gonzalez with TDI's Public Affairs Division. Any questions that we don't get to during today's session, we'll try to follow up with email later on. But you can always email any questions, even if you think of them later, to lifehealth@tdi.texas.gov. Lifehealth, one word, at tdi.texas.gov. All right, joining us to answer your questions is our presenter, R. Michael Markham. Michael is the Chief Actuary, for TDI's Life and Health Actuarial Office. His team reviews filings, conducts analysis, and provides actuarial input for our rulemaking. And also joining us on the Q&A panel today is Bing Wu. Bing's an actuary for TDI's Life and Health Actuarial Office. He's one of the actuaries that will be reviewing these ACA rate filings. And Sean Fry, the team lead from the Accident and Health Program, is here. Sean's going to help address any forms-related questions we get this afternoon. Okay, before we get going, just one last thing. Any questions about a specific company, we're going to need to answer those offline. So you can go ahead and email us those questions. The same email, lifehealth@tdi.texas.gov, and we'll get back to you with an answer. All right, you guys ready for questions?
Sure, bring them on.
Excellent. Okay, let's start off with this. Can a policyholder lose their existing plan options due to the rating area's realignment?
No. The rating area realignment just sets rates. In the state of Texas, we have guaranteed renewability for those that are enrolled in plans. So members that are currently enrolled, they will be given an option to enroll in the plans for the next year.
Okay, sounds good. This is a two-parter. First part, it appears that the new AV and cost-sharing spreadsheet must use federal AV, federal induced demand, and a 1.35 factor for CSR plans. Are we required to use those same factors as we develop our rates?
I'll let Bing answer that one. Get into some of the details there.
The answer will be the pricing AV that company using proprietary model can be different than the AV that calculated from CMS.
Okay, so it can be different then.
Correct.
Okay, the second part of that question was, the rules do not mention a standardized plan option Will Texas continue to operate as a federally facilitated exchange, meaning the standard plan options are going to be required?
Yes, Texas will remain as a federally facilitated exchange, which means CMS will still be running the exchange for the state of Texas, and the standard plans will still be required.
Okay, sounds good. Next question. Is it TDI's recommendation that annual network filings are completed using the new rating areas versus individual counties?
I believe that question it seems unclear. It seems to address the network adequacy, and the questions regarding network adequacy should be addressed to the MCQA. But if you have a question regarding the networks, feel free to email it to us and we'll forward it to the correct departments. But for our rate reviews, we look at them based on rating areas.
Okay, sounds good. Rating areas, not the counties. Next question. Initial rates are due to TDI when? Is it 6/15?
That's
June
right.
15?
That's right. Initial rates are required to TDI by 6/15. One reason that we require this date is so we want to be aware, particularly of companies that do not plan to refile, because we want enough notice prior to the 180-day cutoff so they can at least receive notice of that so they're not in violation of a state law. And also to give us a head start on doing the reviews of each one of these filings.
Okay, sounds good. Next question. Will a redacted version of the ACT memo be permitted or honored for public view?
Yes, and this actually brings up a point I should probably clarify. As you submit your filings in SURF, it's important that you click the button to ensure that they are confidential, so that they will not be released in case we get an open records request. And we will honor the if they are filed as confidential, we will not release that information. So.
Okay. Next question. Will the enrollment data that the state receives in the Texas template reflecting enrollment as of March 31st be made public?
No, it's not our intention to make this public. This is collected for internal analysis of the market. Some numbers might be released in an aggregated form, but there's no intention to release it on a company basis.
Okay. Do you know if carriers need to file on both the HIOS and SURF now that Texas is an effective rate review state?
Actually, they just have to file on SURF, because we are an effective rate review state. CMS can get the necessary information directly from SURF.
Okay, so that cuts out one there. Less to do. You mentioned funding for insurance needs. Are there going to be resources available for those with low incomes besides Medicare and Medicaid, CHIP, something like the stimulus that was used for rent and mortgage assistance?
Well, we're probably not the best source to ask questions of this nature. But of course, if you ask us those, we will try to forward them to the correct department for an answer.
That's perfect. You can email us those kind of questions and we'll pass them on to the best source we can find. Next question. Is there any calculation of the cost of deferred and delayed treatment on population health?
I'm not sure I understand that question.
Is there a calculation of the cost of deferred and delayed treatment?
Would you like to try that one, Bing?
I'm assuming that it's reference to the pandemic, that the utilization being postponed. That's what I'm guessing, but I can clarify from Greta on that.
The specifics of the filing we'll look at.
Yeah.
Right.
Okay, moving on to our next question. If Texas is no longer a direct enforcement state, does this mean we no longer have to submit form filings to CMS and SURF for review? Do we know, has CMS officially acknowledged Texas no longer being a DE state?
I don't know. Would you like to take a stab at that one, Sean?
I think the forms still need to be filed with CMS. So I think it's only on the rate side, and kind of that's a good question, probably a good segue into when you file the forms on the Texas side, just do a cross-reference to the rate filings, because this is something we're going to ask for. That could either be in the court file. SURF has a place for corresponding filings, or there's, filing description. You can include that information as a cross-reference to the SURF tracking number for the rate submission, because something we're going to ask you for. So, but still, the forms need to be filed with CMS and with Texas as well.
Okay, thanks, Sean. Next question. Are IDF factors also being prescribed along with the mandated CSR load of 1.35?
Yes, that's an easy one to answer. Yes, the IDF factors are going to be prescribed. The 1.35, of course, that the CSR sub-factor would only apply to silver plans which are on the exchange.
Okay, in relation to that, if the silver load for the CSR is more or less than what is needed, are we allowed to adjust our index rate up and down to offset the silver plan being over or underpriced?
Let's see. I understand the question asked if they can adjust the CSR sub-factor.
If the 1.35 silver load for CSR is more or less than what was needed, can they adjust the index?
No, this right here is to reflect a statewide average. So the 1.35 sub-factor will be prescribed for all carriers.
Okay. Next question. It appears that the new AV and cost sharing spreadsheet must use the federal AV, federal induced demand, and a 1.35 factor for our CSR plans. Are we required to use that same factor in developing our own rates?
Okay.
I think we kind of answered that question earlier. So the pricing factor doesn't need to be reflect the AV from the actuarial value calculated from CMS.
Okay. Yeah, we had a couple of people with similar questions. Can the IDF factor vary by plans within a given metal level to reflect these AV differences within that metal level?
No,
Go ahead.
Sorry. Go ahead.
They just included an example. If we have a bronze plan with a 60% AV and a bronze plan with a 65 AV, are we required to apply the 1.0 IDF factor to both of those, despite the AVs being different by several percentage points?
No, the induced demand factors are going to be fixed based on the metal tier.
Okay, so those will be fixed.
Yes.
And yes, we're going to distribute these slides after the webinar. We'll send you an email with those. Do we know when the new ratings areas go into effect, and will the change apply to both individuals and small group markets?
Yes, they will go into effect for the 2023 calendar year, and it will be effective for both the individual and small group markets.
Okay. Is there a deadline for refiling post-final risk adjustment report?
The dates that you should keep in mind with regards to filing rates, and this is particular for plans which you want to have on the individual exchange, is that the deadline to have these rates finalized to CMS is on August 17th. So you want to give us sufficient time to review the rates to show that they are justified so that we can approve the rates. Now, if it's not on the exchange, you have until October 17th.
Okay, thanks, Mike. Does each county provide county health insurance for those who do not have insurance?
That's not a question I can answer. But if
Yeah.
they want to submit it to us, we'll see if we can send it to the right area.
Yeah. All right. Will a silver plan offered both on and off the exchange be permitted to use a weighted CSR load, the 1.35 weighted with a 1.0, based on the projected on and off exchange distribution? So obviously we'd probably expect that weighting to be very close to the 1.35.
Oh, I don't know. Bing, you want to try that one?
The silver loading factor is only allowed to be applied to the unchanged. I think the calculation based on the both, though, I agree with that.
Okay, our next question here. Let's see here. This is the actuarial value and cost sharing reduction factor design template going to be new for this year? And if so, will it be posted on the website or auto-populated on SURF?
Okay, I'm sorry. Is that, can you say the question again?
Sure. They ask, is the actuarial value and cost share reduction factor design template new for this year? And if it is, are we going to have that on the website, or will it be auto-populated over on SURF?
Yes, actually, it is new for this year, and it will. We're working to get it up on the on SURF, the template.
Okay, thank you, sir. Will TDI transfer rates over to CMS for review automatically if we go through SURF?
Yes.
Straightforward.
There
Yes.
we go. Yes.
Does TDI expect the URRT's current enrollment to reflect the March 31st enrollment for the template?
No, the March 31st enrollment is just used for internal analysis to track enrollment for internal purposes. That's the only purpose for it.
Okay.
It's independent of the review.
There was a mention of the costs of the increased use care at higher metal levels. Can you talk a little bit about that?
There was a mention of the cost of the increased used care at higher metal level. I believe it has to do with induced demand. And I gave a brief description that people who have poor health are more likely to buy a richer plan. And that is one reason that the induced demand factors are higher at these richer plans. And of course, another factor is if someone has a richer plan, their cost sharing is less. So that will also have an impact on the induced demand.
Okay, thank you,
That's
sir.
just really just an explanation of where they come from and what those values are.
Okay. Another question. Will TDI allow carriers to calibrate the IDF factors and apply that uniform calibration to all their plans, just multiplied by the metal specific IDF?
No, the IDFs are going to be required to be fixed by metal tier.
Okay, so just match those up with the type of metal.
Yes.
All right. Will we be providing the location of the enrollment template and the new AV CSR template?
Yes. Of course, if you have any questions, feel free to email us, and we can identify where those are at. We can send you one.
Okay. Next question. Do you expect carriers to use the raw fed IDF factors, or can carriers use normalized IDF factors? Meaning, is it the same relativity across the metals, but the weighted average of that IDF is 1?
Go ahead, Bing.
We expect that the carriers just apply the Fed's recommended IDF factor, not the weighted average or not the same ratio.
Okay. Do we know, have the rate filing requirements discussed in these slides already been published in SURF?
Oh, you talk about in regards to the individual templates.
Yes.
So we are working on to set it up, basically loading the enrollment template and also the cost sharing AV template to load on SURF. And my expectation is it will be set out as a required template for carrier to download and then upload back for the submission.
Okay, thank you, sir. Does TDI have a preferred approach for filing rates, assuming ARP subsides are renewed versus if they expired?
Oh, yes, this is the yes, the American Rescue Plan. Yes. Currently, I would recommend just following the rates given the current guidelines. And if there is a change, then they will simply have to refile.
Okay, thank you, sir. Okay, as part of the presentation, it appeared that the CSR load of 1.35 also included the prescribed induced demand factor.
Yes.
The product of the AV load and the induced demand must be 1.35. Is that correct?
Yes. Yes. The increase in induced demand is included in the 1.35 factor. This is actually a requirement of the Senate Bill 1296, the recently passed law, that we incorporate this adjustment in the factor.
Okay, here's ones that a lot of folks would probably be interested in. How much time do you anticipate it's going to be reasonable for TDI to review prior to the 8/17 deadline?
I will let
As soon as possible.
So our goal is to review, so the carrier is supposed to file an initial rate by June 15, and our anticipation is we will go through our review, meaning including objection, to complete the review within 60 days. For individual unexchanged filing, CMS does have a hard deadline on August 17 to be completed. So that will be what our priority will be focused on.
Yes, if I don't anticipate a problem if they file, if they file the rates, say by July 15th, I certainly wouldn't recommend waiting until say the middle of August when you're under the crunch to have these rates reviewed. So when you get the risk adjustment report, you have to adjust rates. Please do it as soon as possible.
ASAP. All right. Next question. Is there a cost? There is a cost to delayed and deferred treatment of population health. Can we add that? Can that be calculated?
Okay, you want to take a shot at that, Bing?
Yeah, we have seen carriers file that particular impact in their rate filing, and usually that will be categorized in the mobility adjustment. When we review that, we usually ask the company to provide also extra justification to include it.
Okay, thanks. Based on the slide on development of the CSR load, it appears that the 1.35 already reflects the induced demand. Does that imply that we would not apply the prescribed silver induced demand factor to the applicable plans as induced demand? Would it be counted twice?
The IDF subfactor, which will be will be a 1.03, so you'll have that. The CSR subfactor will be a 1.35, which already takes into account the increase in induced demand based on the higher richness of the CSR plans.
Okay, we've only got a couple more minutes. Let's try to run through some of these. To follow up with regards to resubmitting rates for review post the risk adjustment, but before August, the CMS deadline, is it safe to say that mid-July to TDI would be sufficient time for review?
Yes, and this kind of just as a point, if you're just adjusting rates based on risk adjustment, I would say mid-July should be sufficient. But if you have a complete revamping of the rates, besides the thing of risk adjustment, you might want a lot more time. But just an adjustment based on risk adjustment, mid-July should give us sufficient time to review the rates.
Okay, thank you, sir. Will TDI be consider the 15% heightened rate increase threshold especially given the mandating of the CSR load, depending on the carrier's prior load that might not have been as generous. There could be some sizable rate increases on these silver plans.
Right, right. Go ahead, Bing. I'll let you answer this one.
So for a higher rate increase, there is still a higher of CMS requirement for carrier to create a written justification on rate increase. And TDI doesn't have a specific threshold that we say, oh, you cannot increase in rate to. However, you do need to meet the medical loss ratio requirement when you adjust the rate, and we will review accordingly, I guess.
Okay, sounds good. I'm afraid we're going to have to wrap it up there. We've got several other questions, but we'll have to respond via email because it's 3 o'clock here. We're out of time. If we didn't get your question from the Q&A, or you think of something additional that was just not being covered, go ahead and send them to the email that I mentioned earlier, lifehealth@tdi.texas.gov, and we'll try to get back with you as soon as we can. All right, thanks again. Have a great rest of your day, and we'll see you next time.